young adults. So I love this slide. We had a vote, and so this slide won. So I'm going to just provide a brief history lesson. So according to my records, the first evidence-based care for first episode psychosis program was established in 1992 in Melbourne, Australia. So we often talk about the RAISE study, but I paused and was wondering, like, do we really explain, like, what does that mean? And so essentially RAISE was looking at or questioning, well, can we do that? Will that work here in the United States? Can we implement that team-based program model here in the United States? Will it work? And the answer was yes, that it was impactful. The individuals that had the most effect, that benefited the most, were those individuals when we talk about that shorter duration of untreated psychosis. But overall, there were just greater improvements in clinical and functional outcomes. I do realize that we talk about outcomes often without really clarifying what that means. So in regards to coordinated specialty care, we're talking about less distress, lower risk of relapse, a reduced family disruption, which that's huge. We oftentimes don't include family when we're talking about those outcomes, and the individuals that we work with are in some type of family, however they define that, but they're in some type of family unit. We're helping that individual also have reduced hospitalizations, and then also just overall lower healthcare costs to the individual living with psychosis, to family members, and then to society overall. So we know coordinated specialty care is impactful. We just talked about the benefits. Why are we here? Well, unfortunately, what we also know is that 30% of young adults disengage in treatment within the first year. And in one of these articles, in the Brightboard and Mo article, they talked about situations where up to 80%. So 80% of young adults disengaging in treatment. So what can we do about that? Well, Myers et al., they talked about, they wanted to focus on pathways through care. So they said there have been much attention on pathways to care, but wanted to focus on how do young adults make decisions about treatment and engagement, and for us to determine how young adults actually move through recovery. As I was preparing this slide, I did think about how just last month that Dr. Kreider and I were telling you, maybe don't use the word normal. The word normal can be off-putting, and it still can, especially when we're talking about behavior. So not normal range of blood pressure. But in regards to behavior, there may be some things that people think, Crystal's a little quirky in that area, or maybe I wouldn't do that, but that's my normal. However, I am trying to do a better job of actually listening. And so for these young adults, they stressed that they wanted to get back to normal, and returning to normal was focused on school and work. So when we're talking about those barriers of, well, what's going on? Why are young adults disengaging? They talked about not feeling heard by their provider. There was also a desire to be able to speak to someone with lived experience. And I hope you joined us last month where we were our peer support specialist, amazing presentation, and it seems to fit perfectly right here. And then also, I do like that Myers used the language of key supporters. So I do want to pause and tell everyone happy Pride. So key supporters doesn't necessarily mean biological family. It's really about who are those people that are important, supportive of the young adults that we're trying to engage in treatment. Some of this, again, in Myers et al., this was 2019, some of the young adults expressed concerns with police involvement. So think about maybe a key supporter, a friend calls the police, and for many of these young adults, they stress that if there was a bad interaction, then that reduced their interest in outpatient healthcare treatment. This particular quote actually came from another Myers and Ziv. And this individual, his mother called, and he was walking on the street. And the quote reads, "I went to outpatient treatment, maybe 1 year study, but I was still not in agreement from my diagnosis, especially the way it all happened, them arresting me and stuff." And there was another quote where Mark, one of my favorite names, he was quoted as saying, "I felt like a criminal on my own street." And so he carried that with him for a very long time and ultimately disengaged in treatment. Another concern that some of these young adults expressed was medication. So if we're thinking about first episode psychosis, many of them might not have ever been on any medication. And so some of them reported that they were feeling worse or that they were feeling like a robot. So this is our little robot here. There were a couple other concerns were also the social pressures of using substances. So not just don't use. I mean, many of us know that it's just not that simple, but also wanted to be able to talk about the social pressures of using. So more likely in the before, but if young adults were going to parties or going to their friend's house, they want to talk about like that pressure is real. So it's not just about don't use, it's like, how do I navigate these situations where maybe I don't want to use, but the people around me are using. And then again, I just want to highlight it. There was a lot of concern around hospitalizations and associating that initial hospitalization with mental health care. And I thought about, for a long time, I supervised case managers. And so if we were doing field supervision, we would oftentimes go to the hospital. And there is something about putting all your belongings in this locker, pushing that buzzer, and you walk in this door and the door locks behind you. And we knew we were getting out. We would spend a few minutes there, we were leaving, but just whether we think the individual should be there or not, just thinking about that young adult's lens and them in this place, maybe not having their own clothes, they can't shave, and it's locked, the door is locked. So for many of them, they disengaged or never fully engaged after that initial hospitalization. So this is one of my favorite slides, and it pops up in different places. So one of the things that the youth just really were asking is not so much focus on the label. So understanding that as clinicians, you're having to come up with this diagnostic label. But in regards to engagement, in regards to the young adults treatment goals, they are asking that we just focus on what they want to focus on, their treatment goals, and not so much that label. I did think it was interesting that also Brightboard and Mo talked about developmental stages. Just want us also to think about young adults and where they are. So it's, the identity formation, establishment of autonomy and independence, and thinking about how does that relate to their treatment goals. And I guess I'm just driving home here that, again, when asked their top 3 treatment goals, employment, education, and relationships. So not remission of symptoms, right? That wasn't their top 3. If that happens, awesome. But their top 3 goals were employment, education, and relationships. So now that we've addressed some possible barriers, what are some treatment interventions? What can we do about to decrease some of these barriers or to just move them out the way? And so we have some very practical interventions, shared decision-making, which is a foundation of coordinated specialty care, but always just want to reinforce that it really does help the individual clarify their preferences and values, and ultimately helping that individual to find their own power, and so they can play an active role in their treatment. We know that there are many benefits from family psychoeducation. So again, when we think about those developmental stages, however, oftentimes there's going to be possibly a push, a pull, I need you, I don't need you. So on the support side, we know key supporters are an advocate, a very strong advocate for young adults. They can help them maneuver through what can be a complex healthcare system. And sometimes they're simply providing tangible support, transportation, housing. But there's also that side where young adults want to be independent. So something practical could just be separate sessions. So some of you might already be doing this, just looking at how can I try to keep that key supporter engaged. So having a session for that individual, but if possible, then also having a separate session for the young adult. And then also a tangible option is that release of information. And I know that can be challenging. It really depends where the individual is. But I know my colleagues, they will talk about like hitting while the iron is hot. So maybe you ask and they say no, but if you see another opportunity, then bringing it back up. So then again, we can communicate with those key supporters. And then peer support again, that was one of the interventions identified in a couple references. I think, like I said, last month really set me up actually for this presentation, but even talked about moving a little beyond what we traditionally think about as peer support, and can that person with lived experience outreach someone early in treatment? So not doing an assessment, but just maybe trying to gauge the individual's interests, and then also sharing their experience. And then also in regards to community outreach, we're constantly talking about outreach, letting the community know the coordinated specialty care is available. And so I was thinking about, well, people aren't getting out as much, but there's been, as we're doing right now, there's actually been more, partners coming together, stakeholders coming together through video conferencing. And can, peer support be available? Can that individual talk about their experience when you're trying to outreach your community members? Social media, this came up, and it's just really, who's behind your social media account. Logistically, it may not always be what we call a quote unquote young adult. However, possibly getting some input, getting some input from young adults. There was an example of an organization in Florida where the logo for the actual organization didn't change, but they incorporated input from young adults. And so for that particular program, they were able to create an additional logo. And it was another way to keep the young adults engaged. And this kept coming up, but I felt that you could actually tell me more about your experiences in regards to telehealth, audio, mobile services. Obviously, I started my research before March, but I know that many of you quickly, had to put yourself in a place where you provided these services. And so I was just wondering, we can talk about this as you're introducing yourselves. What practices have you found to be effective? What were the opportunities for growth and further development? And then also digital disparities, because I know that I've even talked about, well, this has been an opportunity for, increased technology, but many individuals do not have access to routine, ongoing internet services. And in regards to equity and justice, I was trying to come from an asset perspective. And so there was a webinar with NIMH in regards to increased suicide rates among Black youth. So I actually have that at the end of the PowerPoint as a resource. And so increase awareness and access to care for Black youth. So just to turn that around, if we know there's an increased rate, what can we do about it? How can we increase access? One, affirming adults. So according to the Trevor Project, for LGBTQ plus youth, if they have one affirming adult, that decreases their risk of suicide by up to 40%. And then I'm one of them people, I'm always thinking about intersections. So I'm thinking about, what if someone is Black, trans, and what if they're in a wheelchair, right? So when we think about accessibility, sometimes it's difficult to find affirming services. And there was a situation where the agency was well known for the welcoming services, affirming care. You could get in the building if you were in a wheelchair, but you couldn't use the restrooms. So obviously that was an area for improvement. And then just also thinking about someone from the LGBTQ plus community that is also Black, some of those traditional what's the word of what? Some of the traditional support, such as faith, such as family, might not be available. And so just remembering as you're working with individuals that you might be that one affirming adult. And I just like this quote. And so psychiatry must learn from anthropology that culture considerably more than shape illness. And I will be honest, I am not seeing it as well. But I will say that culture shapes the very way we conceive of illness. So it's just actually wanting us to expand our view of culture when we're working with individuals in the community. So thank you, and that's all I have.